We know now what is endocarditis. We also know that there are two types of endocarditis, acute and subacute. Acute mainly involves the natural heart valves, whereas subacute is for the abnormal valves, natural as well as prosthetic health valves. And it's generally a thrombotic event which leads to the endocarditis initially. So there are both thrombotic and non-thrombotic kinds of endocarditis which are there. So we were looking into the anatomy of the heart valves, where you have the chordae tendineae and the smooth surface. When there are microclot formation here due to any turbulence or any disease, that becomes the seat for the bacteria to sit on and multiply. We also talked about that when the valves become deformed due to the vegetations or the scarring repeated, those kind of things. So there is a flow which is being, there is a backflow to the atria from the atrium which leads to murmurs. So which are being auscultated, which can be auscultated to identify the bug. We also started with the discussion that there are different kinds of heart valves which are available, which you see on the left hand panel, and they have lot of rough surface around. So the patient who is having transient bacteremias or the in any form the bacteremia, then there is a risk of that bacteria to sit on these rough surfaces and multiply and leading to the endocarditis and ultimate damage to the heart valves. This is again a picture just to show you that the vegetations which are there on the heart valves can be very, very small to large. So depending on the duration of disease and the pathogen, it varies from patient to patient. So this is a aortic valve which is being aortic way of the tricuspid valve which is being looked into. On the surface of this cusp, you can see there are thrombi which are there, which becomes the part of the endocarditis. So primary risk factors for infective endocarditis are associated with the heart valve damage by rheumatic heart disease. This was the conventional way in which it used to happen. Then there is a healthcare contact. Healthcare contact here means healthcare associated infections. So the patient is admitted for something and then develops bacteremia there in the hospital that can lead to the infection which is leading to the infective endocarditis, because healthcare associated infection, as we know, are caused by multi-drug resistant bugs, so they are not easy to treat. So longer the bacteremia, more is the chance of getting the endocarditis. Nowadays, injection drug users, so they are also part of it. So what we learned till now is that the heart valves with surface which is normal or abnormal, natural or prosthetic, all can lead to infective endocarditis if bacteria is present in the bloodstream. Now, bacterial presence in bloodstream it can be transient, it can be continuous, it can be intermittent. The common condition where it is transient, transient means that bacteria has been spilled over because of some activity. However, the immune system is able to take over and clear that bacteria within 2 hours. Right? So that is the transient. For classical example is dental treatment. So pulling of tooth, so there will be a lot of oral flora which is being spilled into the blood, but body can take care of it. Same is the dental brushing, simple dental brushing in the morning, that also leads to the transient bacteremia. Then endoscopic, so any kind of gut handling when happens, or urinary tract infection, which can also lead to transient bacteremia. On the other hand, the continuous bacteremia are where you have the focus within the blood or the lymphatic tissue. So there is a bacterial circulation which happens again and again, and it's more continuous. So where bacteria is not being able to clear up because of the difference in the immune response, that will lead to the continuous bacteremia. So example here is a bacterial endocarditis. endocarditis, endovascular infections, typhoid, brucellosis, leptospirosis, and all. Similarly, in between picture is also there where intermittent bacteremia occurs. So there is a localized infection and then there is a spillover into the blood. So blood spillover is being cleared by the immune system. Friends, in the ratio of the bacteremias which are endocarditis and which are not endocarditis. So if you see the lesser common bugs which are the patient is having, because non-endocarditis bacteremia by bacteria is not that common, right? On the other hand, the other routine causes of bacteremia, the endocarditis uh, is being caused, but it's lesser extent. So they may be treated that way. Among these group of cocci, we have already decided now take whatever it is. So Viridian streptococci, so it has been classified into 5 groups. Metis, anginosus, mutans, salivarius, and bovis. All are there in the normal saliva, right? So they are the source of endocarditis. The common characteristics are the alpha hemolytic, they are alpha hemolytic, but they may be few non-hemolytic. And they are optogene and resistant and bile non-soluble, so that is being differentiated or helpful in differentiating it from the Streptococcus pneumoniae. So that is another important thing to remember. So this slide is showing on the top of it the difference between the alpha hemolytic, these are the alpha hemolytic colonies, the other one left upper is the beta hemolytic and non-hemolytic. The lower batch is showing the optogene susceptibility and bile solubility. So bile drop has been added here and you see the clearing of the colonies. So there are colonies have dissolved in, which were like this here. So these two things are characteristic of Streptococcus pneumoniae. If these two things are not happening, then it is Streptococcus viridans group. Another important group is the Haemophilus group of organism, or it is also known as acid group now. So this Haemophilus group is nothing but the group of 5 bacterial or genera which can cause endocarditis. These all are fastidious gram-negative organisms. Fastidious means slow growing. So Hemophilus Aphrophilus is the most common species in the Hemophilus, which is part of endocarditis here. Actinobacillus, which is now known as aggregatibacter species, that is also there. Then Cardiobacterium hominis, Aikinela Corrodance, and Kingila. So 5 to 10% of the community acquired native valve, that is natural valve endocarditis cases, in patients who do not use IV drugs is caused by this particular group of organisms. So these are again the oropharyngeal commensals, where the Aikinela and Cardiobacterium is being isolated from GI tract and female genital tract as well. Although they are the common cause of infective endocarditis, or they commonly cause infective endocarditis, they are also associated with other localized infection, from wound infection to soft tissue abscesses to organ-specific infections. In the Hemophilus, if you remember, when you were doing the meningitis, they are pleomorphic gram-negative bacilli requiring factor X and factor V for culture isolation. However, Hemophilus aphrophilus and not the Hemophilus influenzae here, which is the most common cause of infective endocarditis. So almost 1% of all cases of infective endocarditis are caused by Hemophilus aphrophilus or by parainfluenzae. 10% cases, in 10% of the cases who have the Hemophilus species as a cause of endocarditis, also have viridans streptococcus or Staph aureus being isolated along with them. So that is another important thing. So co-infection with these two is also present. And 45%, almost half of the cases, have the oral pathology, so which is a source of spill to the blood and ultimately the endocarditis, and 10% are with the upper respiratory tract infection. Mitral valve disease or mitral valve endocarditis is more common as related to the aortic valve endocarditis by the Hemophilus species. Second species of Haemophilus group is the Actinobacillus actinomycetofomitans. So it was first isolated from the skin lesion. Actinobacillus israeli, if you remember your skin and soft tissue infection, it is one of the common cause. So it is the species from the same genera. It forms the granules and float at the top of the container. So it can be cultured in a septic soil broth, a liquid medium. So on the top of it, the growth will be floating around, and it has been associated with again the dental pathologies, where periodontitis, one of the manifestation of early onset periodontitis, it is the common cause, and again spill owing to heart. So if you see here, you see the Cocobacillus form on the gram stain. On the blood agar plate, again they are alpha hemolytic colonies, which can be seen, very tiny alpha hemolytic colony. So the infective endocarditis by this Actinobacillus, 86% of the patients have the underlying heart disease. So native valve or without any heart disease, the chances of infection with this valve are much lesser. In contrast to Hemophilus, it is the aortic valve which is more commonly involved by the Actinobacillus than when we saw the Hemophilus. Arterial embolization, if we will go on it, that when vegetations are there on the valve, there is a lot of pressure and the flow which is there, blood flow is there in the heart. So sometimes these vegetation dislodges from their place, and depending on the right hand side or left hand side of the heart, they are being embolized, or these vegetations move on and block the vessels in the pulmonary system or in the other organs, which is the embolization. So that is also affecting the other organs. Next bacteria is the Cardiobacterium hominis. It is interestingly a bit different if you see the gram stain. So it is having the bulbous swelling at both the ends and is characteristically grouped in chain clusters, or what we can say is the rosettes, star-like arrangement. So that kind of thing can be seen. So this is from the culture, so you may not be able to see, but the arrangement is more commented upon when they are coming from the liquid media. So again, it is being secondary to the oral pathology. Mitral valve involvement is higher than the aortic valve. Almost 40% of the patients have the arterial embolization of the vegetation which are there, or by the Cardiobacterium hominis. Again, it is the tiny alpha hemolytic colonies which can be seen on the plate. The Aikinela Corrodance, the other bacteria, which is named because of the colonies which they form on the agar plate. So it corrodes the agar plate where the colony is there. That is why the term corrodance. So gram-negative, pleomorphic, often cocobacillary or rod-like uh, morphology which is seen on gram stain, and there is a bleach odor which is on the plate. So again, they are facultative like the other oral flora, and it can result in cellulitis, soft tissue disorders, infections, and the other organ-specific infection other than the endocarditis. Here, the important point to remember is the Aikinela corrodance is more common with the IV drug abusers, and because of their habit to lick the needles for good luck, the oral flora is being injected by them in their own veins, leading to the endocarditis. So right-sided endocarditis is more common here. Right? And last of the Haemophilus group is the Kingila species. Again, gram-negative cocobacilli. It also causes the pitting of the agar. There are three common species: Kingila King, denitrificans, and the indologenes. And Kingila King is the one which is the most common bacteria which is responsible for the infective endocarditis. Next group of bacteria is nutritionally variant streptococci. They are called so because they have a different nutrition requirement. So they require pyridoxal or cysteine for their growth on the blood agar plate. So they are also known as nutritionally deficient streptococci. So they can grow around the colonies of the other bacteria which produces pyridoxal or cysteine like Staphylococcus aureus, or you need to supplement it from outside to the blood agar if you want to recover these organisms. So generally they are again alpha hemolytic, but few of them are non-hemolytic. So there are two genera which are there in the nutritionally variant streptococci. One is Abiotrophia defectiva, and another is Graniptella. So audience and the elegans, which are the common, and both are responsible for bacteremia and endocarditis, and because they are causing bacteremia, they are also leading to the brain abscesses. Last in the causes is the Enterococcus in the bacterial causes. It is a group D streptococci. If you remember the Lancefield grouping, so A was group A streptococcus, which was Streptococcus pyogenes. B is the Aguilactae, and then you have alpha hemolytic streptococci, in which you have the D, right? So in the alpha hemolytic, you have a separate Streptococcus pneumoniae, which is not group D, but is a separate entity. So in the group D, we have the two common species, which is Enterococcus faecalis and faecium, which are being clinically relevant, although gallinarum is also increasing in number now. So again, they are the normal gut flora. So any gut intervention or pathology or instrumentation due to healthcare associated infections can lead to bacteremias because of the enterococcus and ultimately the endocarditis. So if you see the morphology of the enterococcus, they are gram positive, bit oval shape, and generally seen in pairs. And they are bent at certain angle to each other, the two cells. So that's the characteristic of the enterococci. they are bile esculin agar. 40 they grow on 40% bile esculin. Right? So this is the bile esculin which is changed into the color of the true black from the normal pale color medium. They can also grow in presence of 6.5% NaCl. So the comparison here is with the certain streptococci which also do the reaction on the bile esculin agar. So they can be differentiated for their growth on the 6.5% NaCl or sodium chloride. Potassium telluride is being used to selectively isolate and identify where they produce the black colony. A conky agar also can be used where they can grow as a very tiny magenta color colony. And these are the two non-hemolytic. So enterococci can be beta hemolytic, alpha hemolytic, or non-hemolytic. All kind of hemolysis can be seen around. This is the Ficalis, and another one is the Fisher. So they have also a property of heat resistance. So they can grow to at 60 degrees centigrade for almost half an hour. So that is also being used as a identification test for enterococcus along with the other biomarkers. PYR, if you remember when we were discussing last lecture, group A streptococcus is PYR positive, whereas other streptococci are not. The enterococci again is the positive PYR reaction, and in addition to it, you have the another test which is leucine aminopeptidase, which is also positive in enterococci. To differentiate the two species, Ficalis and Fishium, we can use the arabinose utilization with the bromocresol purple indicator, which helps us to differentiate the Enterococcus faecalis from the Fishium. Another important property of Enterococcus is their intrinsic resistance to commonly used antibiotics. And here the commonly used antibiotics here means the cephalosporin, large beta-lactam cephalosporin group, right, to which it is intrinsically resistant. And there is a low-level resistance to aminoglycoside as well. So if you are using gentamicin or amikacin, it has to be on the higher side of the dosing. Vancomycin resistance is also being seen in the Enterococcus, more common than when we compare it with the other gram-positive bacteria. Van A, Van B, and Van C, these are the three phenotypes which are being there. So depending on the level of vancomycin resistance, they have different phenotypes which are available. Okay, now coming to the clinical presentation, as we discussed, the acute endocarditis is commonly caused by the bugs, which are the common pathogens or causing bacteremias, which include the beta hemolytic streptococci, staph aureus, streptococcus pneumoniae, and so on. Whereas subacute endocarditis is generally by the patient's own flora, which is normal microbiota of the oral mucosa and the respiratory mucosa or the intestinal tract, and accidentally reaching the blood. Endocarditis by Bartonella and these Coxiella burnetii and Treponema pepillae, they are very, very slow because these are the slow growing organisms. So the endocarditis is really slow or indolent in nature in evolvement. And the common feature for all kinds of endocarditis is the fever. Only difference is generally subacute and endocarditis, which is slowly coming up. So the fever is generally low grade and less than 102, 103 Fahrenheit. Whereas in acute endocarditis, fever is typically very high grade. However, there are certain subset of patients which or they have acute endocarditis, generally have a tremendous tissue destruction in terms of uh, the valvular damage and total prolapse of the valve also. So this tissue destruction generally leads to what we called as a murmur, which we have already discussed. Third thing is the embolus formation. Embolus formation, systemic or permanent. So staph aureus, which produces much unkindness, infarction in the spleen or the kidney, and so on. Similarly, the last part is the circulating immune complexes. So presence of antigen and antibody or the globulins which are there, that can lead to what is known as extracardiac manifestation. So classical manifestations which are being described for endocarditis are all these: the splinter hemorrhage, the conjunctival hemorrhage. So this all things are happening because of the circulating immune complexes, because of the subacute endocarditis. So this is a picture just to show that this is the splinter hemorrhage which is being seen at the nail bed, and it can be there on the foot or the hands, although foot splinters are less common as compared to the hands. These red spots which you see around, these are nothing but the ossular nodes. So they are palpable, painful, erythematous nodules which are found at the ends of the finger and toes of the thenar and hypothalamus. So again, this is because of the terminal embolus formation leading to the occlusion and then thrombosis which is occurring into the terminal arteries, which is leading to ossular nodes. This third picture is about the Janeway lesions. So these are irregular in margin and they are painless as compared to the ossular nodes, which are painful. They are painless. Erythematous macules. Macules means flat. There is no raised margin which is there with the same distribution, and the main mechanism remains the same as is with the ossular nodes. Then you can have the vasculitic rash which can appear, or you may see in the CT the end organ infarcts, as we talked of spleen here, which is shown on the CT. So the infarctions are there, or it could be the kidneys or can also. So have the infarcts. So one way of classifying it is the cardiac and non-cardiac manifestations, and we have already discussed all the Or if you have suspected endocarditis and you have removed the valves and changed them because they were defective in any case, and later on it is found on histopathological examination that there is no evidence of endocarditis. So these are the where you are going to change. So lab diagnosis, when we talk of, first is a specimen collection. So generally blood is being used, mainly the blood culture or serological test or molecular test. Second is the uh, tissue or vegetation. So if the valve has been removed, or there are various methods where you can now harvest vegetation. So if it is done, and you can grow that vegetation, grow from the vegetation the bacteria, then you can clinch the diagnosis. When you do the blood culture, the timing, volume, and number of blood culture sets is very, very important. I think this has already been covered into the your bacteremia or piracy of unknown origin. So just to reiterate here, the best time to collect blood is the first patient contact before administration of antibiotic. And if it is not possible and the patient is being referred from the other hospital, the next window is before you pump the next dose of antibiotic. That is the time when the low antibiotic is there and the bacterial level will be high. So the patient is having no history of antibiotic and is having endocarditis. Then fever is being aftermath of bacteremia. So the peak of bacteremia will occur much before the patient is showing the signs and symptoms of the fever. So if you have a particular pattern of the fever which is being seen around, so just before the next peak is due to come, that is a time when you can collect the blood culture. So timing, when we say it's as early as possible before antibiotic, interval between repeat blood culture does not appear to be important here, but wherever feasible, blood culture should be obtained before antibiotic. Whereas in endocarditis, when we talk of subacute specifically, there is no reason or there is no urgency for antibiotic therapy. In contrast to other infections, where you have the urgency of antibiotic, patient is having already prolonged kind of illness which is there. It's not going to deteriorate soon. So that is a time when you should wait for the culture report to establish the diagnosis of endocarditis and give antibiotic therapy accordingly. Another important thing is the volume of blood culture. It has to be optimum volume. More the volume which is being subjected to blood culture, more is the chance of getting the diagnosis. However, the ratio of blood and broth, 1:5, that is a minimum ratio, needs to be maintained. So that needs to be looked into. Third is how many blood cultures to be drawn. So minimum of 2 cultures needs to be drawn, because one culture having the so-called contamination may be the one which is causing actually endocarditis. So if you are suspecting endocarditis, paired blood culture must be sent. Paired means 2 bottles, the blood drawn from 2 different sites, any sites. So that needs to be sent. So in neonates and young with sepsis, high count of bacteremia is there. Bacterial count is per ml of blood is much higher because of the low blood volume. So that is why the low blood volume can do justice in the pediatric patients as compared to adult, where we need larger volume of blood for subjecting it to the blood culture. I'm just skipping all this, and we can come to the next part of it, because this is, I think, has been repeated, which is there. So now the important point is that the microorganisms which are causing endocarditis but cannot be grown on artificial the compiler helicobacter. Fungi, Brucella, this nutritionally variant streptococci, they need special consideration or special antibiotics, especially to be given to the patients. So, patients who do not have received antibiotic during prior 2 weeks, 3 to blood culture is total of two theta. One of the following things are present.